Good afternoon in Brazil. My name is Alexandre Marra. I'm a professor of the postgraduation Stricto Sensu program in health sciences at Albert Einstein Instituto Israelita de Ensino e Pesquisa, and I'm also a researcher at the Hospital Israelita Albert Einstein. I have been researching at the University of Iowa from internal medicine department in Iowa City, Iowa for 9 years. I'm thrilled to introduce our international webinar series featuring guest speakers. This is the first presentation of the year 2025. The international webinar series is part of our global initiative within the post-graduation program designed to connect Brazilian researchers, students, and healthcare personnel with international professors and researchers. It's my pleasure to introduce our guest speaker, Dr. Martineau Louiné. He's a postdoctoral fellow studying metagenomics, next generation sequencing in tuberculosis meningitis at the UCSF. He completed medical school in Haiti and worked for 10 years with partners in health, taking care of tuberculosis and HIV patients. I have been honored to have Dr. Martineau here, and it's been rewarding to collaborate with him on a research project together with Pedro, my son. He'll talk to us about advancing tuberculosis diagnosis, integrating metagenomics and host response insights. We have planned for Dr. Martineau to speak for 35 minutes, after which we'll have 15-20 minutes to answer questions. You can unmute yourself and ask questions after Dr. Martineau's talk, or you can type your question in the chat. I'd like to ask for all of you to answer the survey at the end of the presentation. And thank you, and I will now hand it over to Dr. Martineau to start. Thank you very much, Dr. Martineau. The floor is yours.
Thank you so much, Dr. Marra. It's a real pleasure to be with you today. So I'm going to talk about advancing TB diagnosis using metagenomics and host response. But before doing so, I think it's really important for me. So this is the plan that we're going to follow. I think it's really important for me to give a brief presentation of my journey from Haiti to San Francisco. Maybe that will inspire other people basically to work toward increasing access of care in the world. And I'm gonna give you a brief overview of Partners in Health in Haiti. And finally, we can talk about my project that is like host response in TB meningitis using next-gen sequencing. I want to start my presentation with this quote from MLK. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. I know Dr. Marra gave a brief introduction of my journey, but I wanted to give more insights about it. So basically in Haiti, I graduated from the State University of Haiti in 2006. In my home country, after completing med school, you need to pay back to the Haitian government by working for a year in underserved areas. This is called social service. So I did my social service in a small town in central Haiti called Las Caobas, where I had the chance to work with Partners in Health. And right after my social service, I was hired in 2008 as the head of the HIV/TB program in Las Caobas. And 5 years later, I became the head of the outpatient clinic at a university hospital. And then from 2015 to 2017, I had the chance to take my USMLD test. And then in 2018, I matched at Tufts Medical Center in a neurology program, the residency. And from 2022 to now, I'm doing this fellowship at UCSF in neuroimmunology and multiple sclerosis. So let's start where everything started. So everything started in Haiti and with Partners in Health. So Haiti is located on the island of Hispaniola in the Caribbean Sea. It occupies the western third of the island, sharing it with the Dominican Republic, which is located on the eastern side. For years, Haiti has been labeled as the poorest country of the Western Hemisphere. Let's run the numbers to see what is the situation in Haiti. So the GDP per capita in 2022 was like in the 1693. 59% of the population is living on less than $2 per day. 24% of them are in extreme poverty. Remember, extreme poverty is defined as living on less than $1.25 per day. And the rural areas are where the majority of poverty is concentrated. We have like a high inequality. A small percentage of the Haitian population holds a large portion of the country's wealth, and they want to control everything with the goals of keeping the poorest in extreme poverty. And in 2022, we still have like a high infant mortality rate in terms of like in terms of like death. The maternal mortality is still an issue in Haiti, and the life expectancy in 2022 was like 63.73 years. According to the Ministry of Health, we have like a population of 11.7 million in 2023. The prevalence of HIV is 1.9 in based on data from October 2023. And we still, TB is endemic in Haiti, and we still have issue with malaria there too. So this picture showed you how the health system is built in Haiti. So you have like 3 levels, level 1 from level 3. But as you can see, level 3 is where you have like the specialized hospital. But one takeaway from this picture is many hospitals struggle with outdated equipment, poor sanitation, and inadequate building structure. And to make things worse, on January 12, 2010, lasting 35 seconds, a catastrophic earthquake of 7.0 struck the capital city of Haiti, killing more than 300,000 and displaced more than 1 million people, damaging and destroying more than 80% of the school and 50% of the hospitals. Some people call that it's an acute on chronic situation. So chronically, we had issue, and now acutely we had this earthquake on top of it. And unfortunately, 10 months later, a cholera outbreak killed thousands. So now let's say a few words about Partners in Health. So I've been really fortunate to work at Partners in Health. PIH for Partners in Health is an NGO based in Boston and has been working with sister organizations around the world in some of the poorest regions to help increase access to healthcare in those regions. Zami La Santé, Haiti, that is an attempt of translation of PIH, of Partners in Health in Haitian Creole, is one of these sister organizations PIH has been working with for decades. So one of the PIH founders is Dr. Paul Farmer, that you can see on the picture here. Unfortunately, he passed away in 2022. He was an incredible person, incredible mentor. He was a health activist. He was a fellowship-trained ID doctor. He single-handedly saved countless of lives throughout the world. So Zami La Santé, which is a sister organization to Partners in Health in Haiti, was founded in the early 1980s, to respond to health needs in rural area in Haiti. It has since expanded to a network of 15 clinics and hospitals across the Central Plateau and Lower Artibonite, 2 of the country's most underprivileged and remote regions. To me, one of the biggest realizations of Zami La Santé in Haiti is the University Hospital of Mirbalais. Opened in 2013, UHM offered specialty in emergency medicine, that was the first in the country, gen surg, peds, general internal medicine, and they also have a neurology fellowship. They have like critical care units, oncology, general and orthopedic surgery. And they also have like an open source electronic medical records system. At the end of 2013, I was called to become the head of the outpatient clinic at this hospital. And one thing I have to flag out is the fact that the residency program at the University Hospital of Mirebalais is also ACGME accredited for family medicine and internal medicine, started in like July 2023 in terms of like the accreditation. So when we first opened the hospital, we start seeing a lot of patients all over the country. Neurology cases account for at least 5% of the encounters, and the doctors had some difficulty treating those patients properly. So Dr. Aaron Berkowitz, who is like a neurologist trained at Brigham and Women's Hospital, used to go back and forth to Haiti to train primary care doctors and internal medicine residents in neurology. And this is how my love for neurology was born. So later, with the data from the clinic, we were able to build a neurology fellowship. And here in this picture, you can see the 3 first graduated from this neurology fellowship program. I know that might be something really normal for like a country like Brazil, but one of the things Zamila Sate brought to Haiti is the first CT scan machine in rural Haiti. So with this machine also came the opportunities for research. So we did this research on like head CT findings at a public hospital in rural Haiti. So we were able to analyze like more than 3,000 head CTs between like July 2013 and January 2016. And what we're able to see, a lot of like, basically we try to see what was the reasons the doctor ordered those CAT scan and what is the results. And the results were, so for example, we saw a lot of cases of stroke. And as you can see, 64% were ischemic stroke and 36 were intracerebral hemorrhage. And you see the age, the median age for intracerebral hemorrhage is like it's less compared to the ischemic stroke. We also saw that 17.5% of patients with epilepsy, the epilepsy itself is secondary to neurocystic sarcosis. You can see that in the in the CAT scan, you can see the calcification in the brain parenchyma. And one of the findings that was a little bit like weird to us is the fact that 2% of the patients present atrophy on CAT scan that was out of proportion of age, which means that atrophy means like decreased brain volume. That can happen with age. But when you have patient like at median age of 34 with atrophy, so we don't know whether or not there is some nutritional factors responsible for that. I think the future generation might need to do more research to know exactly why we saw that. One of the strength, I think Zamila Sante is really like a strong organization in terms of like supporting patients socially. So I want to talk to you about those 3 patients. The first one is Janelle. He's a 23-year-old male. He presents to us with progressively worsening headaches, vertigo, and ataxia. He became mute and bedbound. It was found to have this intraventricular mass in the CAT scan. So the second patient, the boy over here, at age of 3, he developed like spastic quadriplegia and was found to have this cystic mass in the dorsal medullary region. And the third patient was a pastor who went blind out of the right eye and starting losing vision in the temporal field of the left eye. And he was found to have this like pituitary mass. Those are really high risk surgeries that you cannot do, that will be dangerous to perform in Haiti. Some people would say that it's not cost effective to bring those patients to the US. It's not sustainable, but this is not how Partners in Health operates. Some of you may know Dr. Farmer's famous quote, "The idea of some lives matter less is the root of all that is wrong with the world." So Paul would argue that cost effectiveness and sustainability are just what rich countries and rich people use to make decisions to allocate resources to poor countries and poor people. But the world has enough resources. The issue is how they are distributed. So we were able to bring those patients to the US. The first patient has what we call a pineal parenchymal tumor of intermediate differentiation and improve after surgery. The second patient had like a dorsal neuroenteric cyst and had a complete recovery after surgery. The last patient has like a prolactinoma, and you were able to preserve the remaining vision in the left eye. And it will be just to show the extent of Dr. Farmer's work. I had the opportunity to take care of this patient before I left Las Caobas. T. Joseph, that's how we call him, is a patient who developed wasting syndrome in the setting of HIV/AIDS infection, and he also had pulmonary TB. So with the help of the staff from the health center of Las Caobas under the supervision of Dr. Paul Farmer and David Walton, so T. Joseph had a great recovery, as you can see in the picture. So this is what I did in Haiti. Now let's move on to my work in San Francisco. So my project in San Francisco, basically, it's to see if there is any, to try to identify unique host gene expression patterns between survivors and non-survivors in adult patients with TB meningitis. So today the talk is not about next-gen sequencing per se, but I wanted to just give you an overview of MNNGS, just to let you know, metagenomics next-gen sequencing technique in CSF, it's largely attributed to researchers at University of California, San Francisco. They really pioneered its clinical use in the early 2010s. And here you can see Joe Derisi is one of the pioneers of this technique in CSF. And Joe Derisi was the mentor of Michael Wilson. Michael Wilson is a neurologist, and Michael Wilson right now is my mentor. So you can see the legacy from Joe Derisi to Michael Wilson to myself. And of course, I had the chance to train Pedro. So yeah, so that's a legacy. And just to say a few words about sequencing, sequencing refers to the process of determining the exact order of nucleotides, like the bases, A, T, C, and G, and to make a DNA molecule that make up a DNA molecule, essentially reading the genetic code within a specific DNA segment or entire genome, that can be helpful to identify organisms and leverage host data. So briefly, this is what we do during the sequencing itself. So first of all, we extract RNA or DNA from the CSF. So we right now at UCSF, we're working more, especially at the lab, we're working more with RNA rather than DNA. And the first thing that we do is we fragment the RNA and to obtain a length size of 40 nucleotides. And then we use random primers and reverse transcriptase to go from RNA to DNA. So we will obtain the first strand of DNA, and then using DNA polymerase, we're gonna like get the second strand of DNA, as you can see here, and we ended up with like a double strand DNA. And then the second day of the prep, we prep the double strand DNA with more products like adapter ligation, and we also add what we call a barcode to the DNA, and we just do a PCR. So the barcode itself is really interesting because like the barcode has like a double role. First of all, it's helped to identify each sample. So basically, at the end of the process for sequencing, if you're working with like 100 of samples, you can mix them together because each sample has a specific barcode to identify it. And the second reason is the barcode itself is important for the sequencing step. So once you're done with your library, this is what you end up. We call that once you're done with your preparation, you end up with what we call a library. that is like a double-strand DNA with adapters and also with the barcodes. Okay, and when we're doing the quality control, you can see this is the library. So the best library should be between like 300 base pairs to 700. And you can see here we have this peak of adapted dimers. You have to remove it because what happened during sequencing, if you have a lot of dimers, they're gonna be sequenced first. So you're not gonna have any result from your library. So that's why we need to do some bit clean to remove those adapted dimers from the library. And after that, we're going to use like a machine. At UCSF, we use NovaSeq, and we also use the Illumina platform basically to do the sequencing itself. So at the end of the day, you ended up like with sequences mapping the human genome, like 97 to 98% of it will map the human genome. And the rest of the sequences will map the like bugs, could be bacteria, virus, or fungi. So that's why we can do host response using sequencing, and we can also do detection of bugs using MNNGS. So now this is the question for my project. Can host response obtained from sequencing help identify gene signatures in patients who survive TBM? So just like a quick review, host response in TB meningitis, TB affect more than 10 million people worldwide, 1.8 million deaths in 2015, and TB meningitis remains one of the most feared complications with like a mortality of more than 50% in HIV infected patients. The TB genome itself is like 4.4 million base pairs long and encodes for approximately 4,000 genes. So what we need to understand that TB meningitis itself, it's like a paucibacillary infection. What does that mean? You mean like few or not a lot of bugs present in the central nervous system to cause the disease. And that's why sometimes it's really difficult to identify the bugs. So the damage that we see in the brain is caused by the host inflammation itself and stroke that are two major contributors to poor outcome. So this is like an MRI, as you can see here. This is a post-contrast MRI. And what we're trying to see here, if there is any breakdown of the blood-brain barrier that we can identify. So when you see those like hyper intensity, that's the sign there is like a breakdown of the blood-brain barrier. And you can see over here in the occipital lobe, you can see this like a ring enhancing lesion. You can also see another one over here. It's a different view. This is an axial view, and this is a coronal view. So those are basically abscesses in the setting of TB meningitis. So what we did in our project, so first of all, we categorize the samples that we have available. So based on the universal criteria in TBM, we define each sample based on whether or not they're definite TBM, probable TBM, and possible TBM. So definite TBM means those are people that we were able to identify TBM in the CSF, whether by gene expert, culture, or AFB smear. And the probable cases are patients who have TB somewhere in the body, but they also have like subacute or chronic meningitis. But we were not able to identify TB in the CSF. And the possible cases are those patients who basically have like in subacute or chronic meningitis, but they don't have they don't have TB anywhere in the body, but they are treated anyway empirically with anti-TB medication. And those samples, they came from Uganda. So we have like a collaboration with the University of Makerere in Uganda, and of course and the Minnesota University. So, and this what we did with all those samples, first of all, we did next-gen sequencing on them to make sure we rule out any co-infection or alternate infections. And the second thing, we performed gene expression analysis to compare gene expression in survivors and non-survivors. So this is what we're able to see. So as you can see here in the definite group, where MNNGS was able to to detect Toxoplasma gondii in one case of definite TBM. So we exclude this from the analysis. In the probable cases, we're able to get 6 cases of Toxoplasma gondii, 1 case of Cryptococcus neoformans, and 1 case of Streptococcus pneumoniae. And of course, in the possible TBM cases, we're able to identify 3 cases of infection, including toxo, VZV, and HSV. So basically, at the end of the day, all the patients with co-infection will be removed from the analysis. All the possible TBM in which we did not detect TB will also be excluded in the analysis, and we're only going to include the definite and the probable TBM. So this is how meningitis performed. So for example, from 64 definite TBM, meningitis was able to detect 49 cases. From the 77 probable TBM, meningitis was only detected 8 and only 2 in the possible TBM group. So this is like a picture to give you an idea of how we select our patients. So basically post-meningitis, this is the post-meningitis patients. So we remove all the co-infection, all the alternate infections. We ended up with the definite and the probable TBM only. And then from this group, if you are HIV positive, or if you receive treatment like anti-TB for more than 5 days prior to your first lumbar puncture, we're going to remove you from the analysis. So that's why we ended up with 109 patients that we include in the analysis. So just to give you an overview, like a demographics of those patients. So we have like 85 survivors and 24 non-survivors. So the mean age is the same. The sex, we have more male in the survivor group compared to the non-survivor group, and it's the opposite in the non-survivor group. And the CD4 count is like 82 in the survivor group and less in the non-survivor group, like 46. So, and then we use the sequencing data, the host data, to check for gene expression analysis between the 2 groups of patients. So we're able to obtain like more than 7,000 genes, and we use this cutoff for each gene. So if a gene has a log fold change more than 1.5 and had like a significant p-value, we consider this gene is upregulated in the survivors compared to non-survivors. If it's less than 1.5 with like a significant p-value, this gene is considered as downregulated when comparing survivors and non-survivors. So this is a volcano plot, like this is all the genes that we were able to identify, and those genes in pink, so those genes are the ones that are upregulated in survivors compared to non-survivors, and those genes are the genes that are downregulated in survivors compared to non-survivors. Some interesting genes that we're able to identify, for example, some upregulated genes in survivors, for example, this gene IKB K beta is required for the phosphorylation induced degradation of NFKB. So that plays a role in infection and inflammation. The second gene, the TRAF3 IP3, plays an important role for T cell development. And also this last gene also play a role in T cell development too. On the other side, we have like those downregulated genes, for example, TOX2. It's a genes that is a transcription factor that can include CD8, that can induce CD8 T cell exhaustion. What does that mean? So basically, at some point, your CD8 will be so tired they will not be able to do their job. And it seems in TBM, we don't want that to happen because this gene is downregulated in survivors. And this gene is responsible for B cell responses. But from our understanding, sometimes when this gene is overexpressed, it can cause cytokine storm when it's overexpressed. And finally, we have this gene that is involved in autophagy pathway. But sometimes you need to do more investigation. You cannot go with like individual genes to have an idea of what's going on. So that's why we input all the genes in like a computer-based software called IPA, Ingenuity Pathway Analysis, just to check for pathway that are upregulated or downregulated. So this is just It's not real data, it's just for illustration only, because when we use IPA, we have so many pathways that it will be difficult for me to have them in one slide. So that's why I try to draw this picture so you can have an idea of the pathway. Basically, all those pathways that reach 4, they are upregulated, they are enriched in survivors, and the opposite in non-survivors. And all those pathways that reach only 1, they are downregulated or in survivors compared to non-survivors. So it's just to show you what's going on. So, okay. So as you can see here, we see, like, for example, I know there are a lot of pathways here, but this pathway, the S100 family pathway, is I think there is like a paper from a group in Africa in pediatric TB meningitis. So this paper showed when you have like S100 protein in the CSF, that like a factor of bad outcome in those patients. So they died when they have like elevated proteins in the S100 protein in the CSF. So as you can see here, this pathway is downregulated in the survivors. IL-15 production is also downregulated. So I have to do more investigation why that happened. Also we have like STAT3, a pathway that is also downregulated, and we know STAT3 is involved in the production of IL-6. So we have to invest. That is a pro-inflammatory cytokine. So we have to investigate why that happened, because as you can see here, co-stimulation by CD20 family is upregulated, and this pathway is also involved in IL-6 production. So we have to know, we have to do more investigation to see why we have this like divergence between those two pathways. So of course, TNF signaling is upregulated. The B cell and toll-like receptor are also upregulated. Other interesting, TCR signaling is also upregulated, as you can see here. So this is the data that we have right now available. So as you can see, we have some components of the adaptive immune system that is like upregulated, and maybe the pathway S100 family pathway that is downregulated is more related to the neutrophils. So we can say for now that there is like a dysregulation of the immune system, but we need more more data to be able to confirm that. So that's why from the same group of patients, we're going to obtain like cytokines data to compare with the gene data to make sure they are telling the same story. So that's the future direction we're going to take. So I want to thank all those people who really had a great impact in my life. Dr. Michelle Morse, Dr. Michael Wilson. This is Dr. Ewan Berkowitz. This is a colleague from Haiti, Dr. Milian Christophe. He's the head of the University Hospital of Mirebalais. Dr. Mintz, and of course, Dr. Paul Farmer, and one of my mentors during residency, Dr. Srinivasan. So thank you so much for your time. So now please let me know if you have any question, if you have any comments. Is there anything I should do to make my project better? So I'm open to any suggestions and comments. Thank you.
Wow, wonderful, Dr. Martineau. I really appreciate your presentation, and are you open to questions now?
Yes.
But I like very much this last slide, because that's one of the goals of the international webinars, that series that I told you, like the relationship between mentors and mentees. And I see this is really strong in your case. And I really appreciate that, because that happened to me, and I'm sure that happened in any researcher's life. We need, we need to be motivated by good mentors, né? And if you have good mentors, this shape, our future, not only academic, but, personal lives. I think that's really interesting. And I'm really glad to see Paul Farmer's picture, because I didn't know that you have a strong relationship with him. Paul Farmer's, to me, and I believe that many friends from Albert Einstein, is like a hero. He wrote many books. I think that I read like 3 or 4 books of Paul Farmer, because he's an infectious disease. And
Correct. Mm.
yes, yes, and I was really sad in 2022 when I read in the news that he passed away. But we are following up Dr. Paul Farmer for a long time, and also because, as I told you before your presentation a couple of minutes ago, that there is a strong connection about Albert Einstein, São Paulo, Brazil, and Haiti, because of the 2010 earthquake. Many healthcare personnel from Brazil moved to Haiti to spend like 10 days. Some guys spend like 1 month working in Fond Parisien, as I told you, an orphanage that we collaborate with other international partners like Harvard, Chicago, guys from Colombia, Venezuela. Everybody try to help in this tragic situation. But my first question is about Dr. Paul Farmer. How was the beginning of your mentorship with him? If you
So
can give us more details.
So that's a great question, and I think the connection with them came from this patient this case that I presented to you guys. So because when I was working at Las Calvas, so Paul Farmer in the past did take care of this patient in the beginning of his disease in like 2003, 2003 and 2004. So he was really vital in terms of like taking care of this patient in the past. And then when I started working with Partners in Health in 2008, 2 years later, this patient that you see here that we saved, he developed like MDR-TB. That is like a resistant form, like multi-resistant like a drug TB. So I didn't know how to take care of the patients because we only had like one institution in the Central Plateau that can take care of these kinds of like patients. So, but the patient itself was like a superstar. So he wanted to stay in Las Caobas because this is where he had family. And frankly, I was anxious of taking care of the patient since I did not have any experience in MDR-TB. So what Dr. Paul did, he flew from Rwanda to Haiti to come, especially to Las Caobas, to teach me about MDR-TB and basically to teach me how to take care of the patient. So this is how the connection got stronger and stronger over time until when I needed to go to residency, he was able to give me a letter of recommendation.
Hmm. Wonderful. Yes, and I like this picture too about this patient that you have in common about the multi-drug resistant MTB, and that was part of the Paul Farmer philosophy, to treat multi-drug resistant tuberculosis, and he was criticized because of that. But he published a paper that its cost effectiveness, there is cost benefit to treat these kinds of patients, and there is an impact not only for one individual, but for the entire world. And yes, this is wonderful, and congratulations, and I'm very happy to have this opportunity to attend your lecture today. Thank you. And
Thank you
thank
so
you
much.
for sharing in so many details that. And let me open. I have a lot of questions because I took a lot of notes. And when you are talking, I was thinking in different pathways, like the metagenomic next generation sequencing. Please, who is in the room. I don't know if they can type in the chat your question. I think that you have it. Oh, João Renato, congratulations for your presentation. Dr. João Renato is one of the leaders in the microlab in our institution, and he is responsible for the metagenomic next generation sequencing at Albert Einstein.
Oh, great.
And you, Dr. Martineau and João Renato, you are in the same paper that Pedro is trying to publish about the meta-analysis. Yes.
Yes.
And
thank you so much.
Yes. João, do you have any question? I don't know if João can speak. Yes. Sandra or Camila, can you open for João Renato to speak the microphone?
João,
you can speak.
Are you hearing me? Do you hear me?
Yes. Perfect.
So,
thank you.
Real pleasure to see your lecture and to know your, not personally, but at least by the internet. I hope one of this day I can go to San Francisco and to talk personally with you. And I think that was very interesting, your presentation. I would have many questions to ask you. I don't know if I follow exactly, but you are doing the same reaction. You are working most with RNA. That's the first question, why you are using most RNA metagenomics and not DNA metagenomics. But I have to tell you that is the same option that we are doing in Albert Einstein Hospital. We are analyzing metagenomics, not only in CSF, but also in blood samples. And we are using RNA metagenomics, and we get very interesting results too. And the most famous is a Tenia solium that we get from a CSF that was suspected of tuberculosis. But we have already published this data. And just if you can tell us a little bit of why are you using the RNA techniques, and if you are that I understand that you are using the same technique to analyze the human transcriptome too. And that is the first question. I would like to ask you which platform, why you are using Illumina, if you have ever thinking in using other platforms such as the Minion, that some people say that it can be powerful, but it seems that there are some problems in the quality of the sequence. These are the two questions that I have. But first of all, congratulations for your work, and I hope that we can collaborate much more in the future.
Thank you so much. So there are like excellent questions. So I think one of the main reasons that like RNA can offer some advantages on like DNA sequencing is the fact that if you are dealing some like RNA viruses, you might miss them if you use like DNA. So if you use DNA sequencing itself, you might lose some RNA viruses, because remember in my project we want to rule out all the co-infection or alternate infections in the CSF, and just to do the host response, just to have like a clean cohort for the host response. So I think going with the RNA offered us this opportunity to pick up more bugs instead of like only using DNA. But in the clinical world, I know they use like DNA. They do both. They do DNA and RNA sequencing in the clinical world at UCSF. So that's one part of the question. So I don't know, do you have any preference in your lab using RNA or DNA?
We are using RNA, because this was the technique that is already we are already using in routine. So
Yeah.
our lab is in fact this reaction is accredited including by the CAP, the College of American Pathology. And another point is that the reaction is much more expensive, is less expensive than using DNA's metagenomics. It seems that is much more difficult to get rid of the DNAs, the eukaryotic DNA, then that is the reason why we are using in routing the RNA. But we are trying to use the test for DNA, but it is taking more time than we think in the beginning, because we have to be sure that we are getting loose of the eukaryotic, the human sequence. That is our biggest problem, and that make the reaction more expensive.
Yeah, but we are Pedro and I, we are doing like a research, like a project on like targeted metagenomics next-gen sequencing. It's for TB. But for this project, we're only using DNA because the reagents available right now to do that, they only work on DNA. So that's something I also need to clarify with you. Okay, so thank you for your input. So, and the second thing is for the platform, I think it's more than like a policy, I guess, because since I've been at UCSF, we've been using like Illumina platform because we have like a dedicated center for sequencing called the CAT. And we are collaborators of the CAT. And they are using the Illumina platform, but I think it's per policy. But I don't know if there is any like relationship with cost and effectiveness. I'm not too sure. But this is what I can say regarding the second question. And I think it's the same situation for you. You are using like Illumina platform, right?
Yeah, we are using Illumina platform because that's the first one we have worked. People say we have better quality, and we have never really tried the other platforms yet.
Yeah, I haven't either. Yeah.
Okay.
Yeah, I think we need some time to talk more about like sequencing and everything. I would be great.
I hope I can go to San Francisco maybe this year. My son and how I say, his wife, they are in UCSF. I don't know how to call exactly the wife of my son in English, but anyway, she's also in the neurology service. She's doing some work, but not in infectious disease. But it will be very nice if I can come to visit.
Okay. Yeah, she's your daughter-in-law. Yeah, your daughter-in-law. Yeah.
Your daughter-in-law.
Yeah.
And João Renato, daughter-in-law, is a neurologist. Is that right, João?
Yeah, he's a neurologist. Yeah.
She's a resident, or she's already an attending?
No, she's in a fellowship.
Okay.
Has finished her residence, and then she went to UCSF. I think she's working in vascular diseases, something like
that. Okay, vascular neurology fellowship. Okay.
Yeah.
Yeah, it's pretty intense. A lot of like stroke, like code stroke, so it's pretty like intense.
Yeah.
You know.
But that's the idea, to make connections between João and Dr. Martineau for future research projects. That's the idea.
She's also working at Einstein at the moment, so it will be a real pleasure to increase this relationship.
And yeah, that would be great. And you never know if at some point we need to go to Brazil to teach like the lab techniques to students. I would be I would like to go with you guys.
Thank you. It will be a pleasure.
Yeah.
Yeah, and I think that this is a really good point, because I heard that in your presentation that you said that the UCSF is a pioneer in metagenomics next generation sequencing in CSF samples. And this is wonderful because, as I know, I was attending a lecture about a CDC guy talking about an outbreak in Mexico a couple of years ago about a fungal infection. I think that's a meningoencephalitis related to periodal anesthesia procedure. And I was really impressed because the CDC submitted the CSF samples to UCSF. And UCSF, I didn't know about that, work together doing the metagenomics next generation sequencing. As you said, it's not only the pioneer, but I think that it is for a while, is the only medical center, as I know, that perform not only metagenomics in clinical, not only research, as I know that other American institutions do research, but research plus clinical practice, like you release, your results for the clinicians to taking care of their patients. Could you make some comments about that?
Yeah, so basically everything started at the lab with Dr. Wilson and Dr. And Joe Derisi, as I showed in the slide, in the previous slide. Yeah, everything started with those two guys. And then right now we have like a clinical MNNGS team led by Dr. Chu, CHUI, Dr. Chu. So basically, you can order your CSF, you can order your test on Epic, and but the only thing is the patient is supposed to get pleocytosis in the CSF. If there is no pleocytosis in CSF, there is less possibility to catch a bug by metagenomic next-gen sequencing. So the main indication, of course, patient can have like meningoencephalitis or meningitis or altered mental status or whatever it is. But for the test to be done, most of the time the CSF itself needs to be you need to have pleocytosis in the CSF. If you don't have pleocytosis, you need to send a message to Dr. Chu to let him know that the suspicion of an infection is really high. Even the CSF is bland. Can you do the test anyway? So that's the clinical metagenomics part of it. And the second part is the lab part. So initially we start with CSF. That was the first component, but right now we move to tissue. So we're trying to see if we can perform metagenomics next-gen sequencing on biopsy tissue from the central nervous system, especially the brain. So that's the second, I will say that's the second phase of the project.
Oh, wonderful. Yes, because that's interesting, because these new technologies like metagenomics, everybody says with so property, that we know that is limited, and I didn't know before a couple of years ago, and you are emphasizing in your talk, and I really appreciate that UCSF is the only place, to do this, and this is wonderful. And you are the right guy to work with Dr. John Renato, in this metagenomics next generation sequencing at Albert Einstein, because as João said, he started with RNA testing, but he wants to add in your portfolio the DNA testing, like you have a great experience at the UCSF, and thank you for that.
Yeah, and of course one of the things we are doing, I was working with Pedro, is to see how we can improve the detection of TB in CSF itself. So that's why we are using this new reagents from a company called Paragon. It's like a more targeted next-gen sequencing. So basically in metagenomics, in MNNGS, we're using like million of random primers, and those primers will basically if there is any, they will pick up like any bugs that are available. For example, if you do your lumbar puncture, during lumbar puncture, you have some bugs from the skin that enters the CSF into the CSF itself. You will be able to pick up those bugs because the primers, we're using like millions of random primers in meningitis. But this technique we're working on with Pedro is more like targeted. So they design primers specifically for TB.
Okay.
So if TB is present, we will be able to pick it up. And but we just need to optimize the technique in the future. So that's the goal. We need to optimize the technique so we can validate the protocol.
Oh, wonderful.
Yeah. Thank you.
Any other questions, João Renato? Do you have any more? I have a lot of questions, but we are limited for the time period of
Yes,
time,
I
like
know.
60 minutes. Do you have any other questions, João?
Yeah, okay. So you talk about tuberculosis that in our meta-analysis was the diseases where metagenomics were the most powerful in detecting it diagnosis. And I wonder if you know that if the techniques that we have included in our meta-analysis were the same ones that we are using, or were these new ones from Paragon that it seems more specific to tuberculosis, as far as I have understanding? Can you make this?
Yeah, so as you can see here, for example, you see we have like 64 definite TBM. So just to give you an example, so those patients, they are patients that we were able to detect TB in the CSF either by culture, GeneXpert, or AFB smear. But as you can see here, the technique that we are using are the RNA. The RNA meningitis that we are using was only able to detect like 49 of them. So Dr. Prashant, who was the fellow before me, he did RNA and DNA meningitis on TBM cases, and he was only able to detect 75% of them using both RNA and DNA. So which means we're still missing 25% of TBM cases. So that's why we're thinking about like optimizing this protocol with those reagents from Paragon that will target TB specifically, because they designed the primer to target TB specifically. But as I said, we need more. We need to optimize the protocol, and this is the goal of the work with the Pedro.
Okay, and my last question would be: are you working only with mycobacterium tuberculosis, or have you done some work with non-tuberculosis?
Yeah. So my project here is mainly focused on Mycobacterium TB for now. But of course, you know, when you're using metagenomics next-gen sequencing, so we have samples coming like all over the world. So you can be able to detect like any bugs in the CSF if the bugs is really present. For example, I remember there was a case from like a small area in California called Chico. So the patient came with some kind of altered mental status. He also had fever, and we were able to detect like a weird bugs in the CSF. And it was like it was a great discovery because we didn't know about it. Let me check for the bug's name. Yeah, it's a Balamuthia mengillaris. So that was the bug we detected in the in the CSF and in the tissue of these patients, and we're able to treat this patient successfully. But if we didn't have a meningitis, this guy would die, because it's like most of the time it's a fatal infection, most of the time.
Yeah, I totally agree. And that's what I was discussing with João Renato because of your work and the other work studies that we were able to read because of the meta-analysis. Like the question is, should the metagenomics next generation sequence to be incorporated as the initial phase of the diagnosis for any meningoencephalitis, you know?
Yeah,
Maybe
that's
yes, maybe
that's a
yes.
good question. That's a good question. I know Dr. Chu from the clinical team will say they use meningitis like in second intention. So basically they will do like the regular meningoencephalitis panel. They will do like the culture, et cetera, et cetera. And then if nothing comes up, they will do a meningitis. But in the real world, in the real world at UCSF, so basically if you have pleocytosis and you have like a meningoencephalitis type picture syndrome, you will get a meningitis. So
yeah, makes sense. Dr. Martineau, thank you very much. And to wrap up your presentation, I'd like final thoughts, if you want to share anything. But before finishing this, I really appreciate and I'm really grateful for you, because you said about legacy, mentors, mentee, and I really appreciate you being a mentor of my son, Pedro, and guiding him in his research projects about metagenomics. Thank you very much. Your final thoughts, please.
That's a pleasure for me to work with Pedro. And as I said, it's like what I did with Pedro, it's like I'm like just paying back what your country did for my country back in 2010. It's a way to pay back. It's a pleasure. So by nature, I'm not like a toxic person. So that's why a lot of people, it's really easy to work with me. And it was like a great opportunity for me to work with Pedro. And I hope we will keep working together.
Me too. Thank you very much. Appreciate it.
Thank you so much.
Have a great day.
Have a great day. Bye-bye.
Take care. Bye-bye.
Take care.
Bye.